opposite.
Supposed to be opposite.
God damn it.
There you go.
Okay. All right. So I'll keep this relatively brief, but succinct. I think I hit the high yield points with fewer valuable images. But indeed, my topic will be clearing the cervical spine. And we'll start with a quote. What I imagine Logan tells his wife when he gets home when he's done a trauma. It's not an actual quote, but he probably said it. But yeah, not particularly relevant to the topic, but it has the word cervical head in it, so cervical spine. Okay, so in all right, so for patients with possible cervical spine injuries, it is still standard practice to initiate spinal mobilization. In the last 15, 20 years, there's been in the field, there's been a slight downtrend in the application of rigid collars. When I was an EMT, when I was 15 years old in the 80s, that's a joke, but they told us always C-spine, always collar. Are they hurt? It's a C collar. I feel like all I learned in EMTB class was C collars. It's still something that we see a lot of. Sometimes we see them not used when they should be used. But in terms of board prep, the boards want us to take a conservative approach to C collars and backboards. So when in doubt on a board question, the general policy, unless it's a nexus or a Canadian C-spine rule question, we should be leaning toward spine protection. With that in mind, though, in general, in unstable trauma, patients will often need their C-collar on, and we can clear that later. It's not a priority to clear it when they're unstable. The topic I'm covering will be clearing it when we can clear it. So primarily, this is going to be discussing our awake asymptomatic patients, but I will address some of the literature for the unstable unconscious patients. And to read from my own side, in those with major trauma undergoing CT imaging of the head, chest, abdomen, or pelvis, the C-spine should also probably be obtained. So, intuitive, but likely empirically, this is not a rule, but just scenarios where you're very likely to need a C-spine. It's not wrong to just automatically get them despite any rules. If they're high-speed MVCs, if there's a death at the scene, fall from height of greater than 10 feet. By the way, notice that this is essentially a list of alpha trauma. Pelvic fracture is not on the alpha trauma list. How would you know? But indeed, if they've got any neurodeficits, C-spine should really be, CT should really be on in your planning. So before I discuss, when and when not to clear or when they are cleared, let's talk about actual downsides to the C-collar. It's an awesome tool, and this is all primarily long-term sequela of protracted C-collar exposure. It's not like you get it right away. That's not what the point I'm making. But these are real sequela you can see in the trauma ICU for those who have been kept in rigid immobilization, especially in the unlikely event they're kept in a really garbage. What's the brand name of the first one that we use? The non-Aspen. We're going to call it the garbage one until proven otherwise. So the first one. It's very plasticky, profoundly uncomfortable, and if that stayed on you for days, I feel like some of these would be more likely. So these are, again, sequela in the ICU, but delayed tracheostomy. You can get it theoretically a DVT. From a jugular vein. You can definitely aspirate, since you're often going to be supine with true spine precautions. Pneumonia, increased ICP primarily by virtue of carotid manipulation and distension and compression. And of course, this is the most applicable for us, difficult airway management. So I would love to know, for the first years, what would be some of your approaches or your favorite approach to a rigid spine immobilization patient that you need to intubate emergently? what adaptations, if any, would you guys recommend?
Using the glide scope.
Okay, wise. I think that would, regardless, definitely be indicated. I mean, this is a traumatic injury. This is someone in a C-collar. Yeah, I mean, how the hell are you going to do it direct with no other adaptations?
You leave the collar on. Have someone stabilize the head while you take the collar out.
Correct. Yes, and counterintuitive. So that's why I asked the first years. I don't expect you guys to know. I didn't even learn that at ATLS, believe it or not. I probably should have, but I learned this with Dr. Kahoot when I successfully intubated with the glide scope without removing the C-collar. And at the end he goes, hey, good job. You probably shouldn't have done it that way. Would not have recommended you do it that way. And I think it was actually Dr. Oba was like, yeah, dude, you should, let's take the collar off, man. But anyway, and the point is, it's theoretically possible to do without the collar being removed, but it's so much better and easier. Yeah, to get that collar out of the way, it allows you to jaw thrust, get the jaw open, get the glide scope in. I don't know how he got it in with his mouth like this. It was a really uncomfortable experience. And yeah, direct visualization, I don't think that's going to happen with someone who's in a C-collar. Anyway, okay, that just. And I appreciated your bold, volunteering answer, but you always want to visualize the chords during an intubation. I see. Cool. I'm sorry. Good. I'm really glad.
I'd like to do it the David way.
And I visualized the heck out of those chords. It just took a long time to get in there.
Throw the whole collar off to the side. You can just like unvelcro that top part.
Yeah, I mean, you unvelcro it, and then it lays flat, on the posterior aspect of their neck. And obviously, if someone who knows that they're holding C-spine, which I didn't have, I didn't delegate that. There's no anyway. Okay.
What if there's a bloody airway in a C-collar?
So,
What do you do?
well,
Break?
the front of the C-collar comes off. If you have a bloody or soiled airway, suction can be your friend, but it's also the enemy of the video we're going to So, the camera can get soiled pretty easily, especially if you encounter lots of victims that have a lot of maxillofacial trauma or neck trauma and have bleeding in the back of the airway. There can be some difficulty in your visualization. You can move to direct if you need to. You need a suction or two to help you out. You can use that as well. And then sometimes you just have to aim for close.
What about fiber optic?
Like, it has the same disadvantages, maybe more disadvantages. Yeah, but in terms of a bloody airway, it's like fresh blood, clotted blood. That's a very small wound thing. You can barely suck up saliva with these things.
And
Even a half hour, it's not great suction, so the fiber optic can be utilized.
And taking that collar off, not only does it give you front of neck access for if you wind up having to do a fright, it also gives you front of neck access so you can do bilateral movement and endoscopy. You have another hand that's not being used when you're intubating, right? And if you need to manipulate the front of the neck, drive yourself out of the view, or guide someone else's hand to get you a more adequate view, that's important. So that's what this allows you to do.
sorry for that aside, but it definitely added bulk to my lecture, so that was great. Minor trauma, intuitively, you'll have a lower but not negligible risk of a cervical spine injury. And indeed, in these patients, Nexus or Canadian C-spine rules should be applied, which will be the majority of what we're discussing today. And because they're minor trauma, you have time and are essentially mandated to do a full neurologic exam prior to clearance. And we have the benefit of time in those cases. So the awake asymptomatic patient. The awake asymptomatic blunt trauma patient is the most common presentation. It's about 30 to 35% of traumatic injuries that we require C-spine immobilization on. And for this purpose, we have the two choices of Nexus and Canadian C-spine. Both good, but one's Canadian. So the inclusion criteria, and this is a more of a broadly learning point. What is the value of an inclusion criteria? Because it's the terms are boring. When I first heard people talking about them, I was like, why do I care about this? Because it means when did the study, like what does the study apply to? Can you use it for your patient? Again, I'm speaking from experience. If that was abundantly clear to you years ago, good job. But it was during residency that I learned that the value of inclusion criteria. And in this case, blunt neck trauma applies for Nexus. It is 99.6% sensitive, but only 12.9% specific, specifically for blunt neck trauma. In the study, only 8.6% of the patients were elderly, surprisingly, actually, because so many of ours are elderly. But Nexus does not risk stratify based on age, and small studies have shown that elderly patients with C-spine fractures don't often have midline tenderness. So obviously they're old, less reliable, osteoporotic, lower suspicion to keep that C-collar on the older folks.
Your sensitivity in older folks may be a lot lower than that 98, 99% sensitivity. It can be as low as anywhere between 65 and 85% in an elderly patient. So I practice pretty cautiously. If I have any suspicion for hyperflexion or hyperextension injury in an elderly patient, even with ground level fall, you can have pretty significant injuries to the cervical spine in elderly folks. If I'm imaging for that.
And that's a segue to a good point that I wanted to make, I suppose, which is these criteria, like a PERC rule in PE, are to allow you to justify not doing a test. If you have your own esoteric reason or suspicion for something, and you're like, dude, I just really want that CT, then get it. This is not trying to tell you how to absolutely live your life. These are giving you instruments to exclude and not scan in the event that you don't think you need them or you're not sure. Uh-oh. We're going to get to that because I think that there is. Yeah. Okay, so this part of this is, so radiography is not necessary if the patient satisfies all of these criteria. No midline cervical tenderness, no focal neurodeficits, normal alertness, no intoxication, no painful distracting injury. So if in the event they have any of this, you cannot use Nexus to exclude, and therefore you can't. You essentially are bound for CT imaging of the C-spine. This is just a nice mnemonic, and I'm sorry, I clearly did not get to the exclusion criteria. I don't know how I managed that.
Age is not an exclusion for Nexus. I think the original study had some patients up to 100 years old, but it wasn't a majority of those patients. It was only 8% of patients in that study. Yeah. So, but Canadian does have age.
We will talk about that for sure, but yeah, I didn't find in my abundant deep research true exclusion criteria for Nexus. But
how do you define, or how do they define distracting injury?
that's a good question. So I can't answer that literally, but I can tell you that my interpretation of distracting injury is a major enough separate physical site of pain or deformity that that you find on your exam that causes pain or
How do you objectify that?
I don't know. I'd love to.
You don't.
Well,
Essentially. So, but even in the original study, there was no objective criteria for what a distracting injury was. It was left essentially up to the interpretation of the provider that was applying the rule.
oh, by the way, going back to this real quick, because Dr. Newton's now here. Thanks for joining, Dr. Newton. I forgot this yesterday. My intoxicated patient, I scanned. I scanned.
They're intoxicated provider.
He didn't ask to smell my breath, but he could have. It would have been fine. But I CT'd so much. I MRI'd so much. And he's like, Singer, please tell me why you didn't CT his neck. And I. And I was like, I mean, there is no excuse. But if I'm gonna invent one, his alcohol was only 153, which was not enough. I mean, I was like, I'm so freaking embarrassed. I'll talk about this tomorrow. So yeah. So I mean, it's important to use the tools that you have. Anyway. Thank you for that. I did not know there was no objectification of the distracting injury. I've always looked at that and been like, eventually I'm going to know what that means. Okay, the Canadian C-spine rule only applies to GCS 15 and stable blunt neck trauma. If they are not those things, you can't do it. It's not applicable to non-traumatic sources of pain or potential injury to the spine, if they are altered, if they are hemodynamically unstable at all, if they're under 16, if there's an acute paralysis or a previous spinal disease or surgery, you can't apply this rule. Those are a lot of different situations where you, like, it's an awesome instrument, but because of these exclusions or absence of applicability, it has more esoteric utility. And this is a nice little flow chart that I'm going to kind of describe in slightly more depth, but in short, I mean, it's not that complicated, which is why I was wondering how I was going to make this a 30-minute lecture. GCS 15 and stable, and the exclusion criteria, high-risk features. Do they have any of the high-risk features? And anyway, so let's go on. Let's talk about these one at a time. So to begin, yes, sir. No problem. Don't worry. Okay, so to clear, first of all, they have to have no high-risk factors. If they're older than 65, they're not clear. Dangerous mechanism, fall from greater than 3 feet or 5 steps. Like there's a reason this is so darn sensitive and specific, because they're like, look, did they get hurt? Like, you can't clear it then. But MVC, greater than 60 miles per hour, that's a very specific number. That's really, really fast. Rollover ejection, bicycle crash, axial load injury, or paresthesias in extremities. These are their specific criteria, but if they have any of those, you can't use this rule. But let's say that they don't have any of those. And then you get to do the low-risk stuff. Do they have any low-risk factor? Do they have delayed pain? Are they sitting up? That happens all the time in our department. They come, someone with a potential C-spine injury sitting up and talking, and so it's something that we can start applying Canadian to. Are they ambulatory at any time? And do they have the absence of midline tenderness? And that's obviously my favorite. I think that's everyone's favorite. If they don't have that, that is a low-risk factor that allows you to move on to the next thing called, can they rotate their head left and right 45 degrees? So essentially, the most common way that this plays out is like they're sitting up, they're not, the mechanism was very minor, you touch their neck doesn't hurt, and then you're like, all right, well then move it. And then they do it, and you're like, okay, well, you're Canadian done, and they really are. Canadian is more sensitive by a mile. It's more specific by like, it's not much more, but neither of these specificities are excellent, but sensitivity is super great for Canadian, so that's nice. Food for thought. But yeah, it's more. There's many more exclusion criteria. So you just have to. It's just know both, apply both, and remember what their purpose is.
Well, and when you're talking about an exclusion criteria in general, you don't worry as much about the specificity. I mean, the whole purpose of exclusion criteria is to have very high sensitivity, so you're not missing something. Part of the reason why they came up with the Nexus criteria is that we were, like way back before Nexus, we were X-raying every single person that came into the ER because they were all getting boarded in college. Like every fall from standing was getting boarded in college. And so the whole purpose of Nexus was to figure out what criteria can we apply that will allow us to clinically clear some of these people to spare some folks radiation. So we do that knowing that the specificity of the criteria that we come up with may not be that high because we're not really worried about, the specificity. We just want to know what are the criteria that we can employ and still be safe in clinically clearing these people without getting radiographs. And so that's why both of these studies, even though they're landmark studies and we follow them, have low specificity because when you're talking about exclusion criteria, you're not really worried about the specificity. You just want to make sure it's highly sensitive so you're not missing something that when you forego the
Yeah.
radiographs.
Absolutely. And to be brief, guys, if we cannot clear using Canadian or Nexus, we have to C-spine, CT them. CT is obviously recommended over X-ray. X-ray is an old school approach. There is less and less utility to an X-ray for this purpose. And for significant injury, CT of the C-spine is 100% sensitive. If there's a negative CT for bony injury, you can clear the C-spine unless they're altered or they have neurologic abnormalities, including paralysis, paresthesias, weakness, etc. There was a really neato burrito study that was later expanded on called EAST. And Dr. Marco, for example, loves talking about this when we're trying to, maybe it was Cahote actually, I was trying to justify applying it to conscious patients. But the point is, they did a study on people that were unable to confirm pain, symptoms, et cetera. And in so many words, when they were essentially unreliable historians, the CT of their C-spine, none of them ended up having an unstable C-spine injury with a negative read of that CT. Really reassuring. Not 100%, but definitely food for thought. The essential conclusion of this is a conditional recommendation that you can remove the C-collar after a negative high-quality C-spine CT alone, and that is and it's medium controversial in the application to conscious patients who are GCS 15. But the food for thought on this, there was a more robust study, multi-center perspective, that supplemented EAST. And again, it concluded a 99.9% negative predictive value for clinically significant C-spine injuries, which does not include ligamentous injuries, which is really the key. And it's not saying you have nothing wrong, but it's saying there's nothing that is likely to be life or limb threatening if you have a negative CT high quality film.
I would say that you can trust the radiologist if you can.
Yeah.
It just, if you have any doubt, just leave it on.
Yes.
So just recently, I'm trying to make it quick, we had an old lady, seizure, ground level fall, no neck pain, decent facial trauma, I just sutured her up. Came back, no neck pain at all. I didn't scan her head, and I scanned her head and her face. And I did scan her neck. I did scan her neck. I didn't scan her back. She came back and saw Franz 3-4 days later for hip pain, plain films. She was walking, sent her home, and then she saw me again at one of the freestanding 2 days later, and she was having like this severe hip pain. It didn't make any sense. Some back pain. So I ended up just scanning her chest, abdomen, pelvis because I didn't know what the heck was going on with her. She was just acting weird. And I was like, what the heck, I'll scan her head and neck again because she's old and not the most reliable. Maybe she fell again. Amadian calls me and he's like, there's several cervical spine fractures that weren't read on the first film. And they weren't significant. and she still didn't have a lot of pain there. I mean, there was a displaced transverse or a displaced spinous process, another spinous process, and then something else. But I mean, she wanted a CTA, and we never did that the first time. And I mean, they were. I pulled up the films, and unfortunately, I didn't review them, which we should be reviewing a lot of these. But I didn't review them the first time. But I mean, they were obvious. Like we could have picked them out. So just, especially when they go to Reston, and we don't have as much familiarity with the radiologist reading them here, you just really gotta. If something didn't add up, you gotta go back and look at those films.
Yeah, I mean, and I think that the learning point there also for, especially for us residents, we really should look at almost everything we film. I mean, I don't look at my ultrasounds that are done formally. I don't know if that's cool or not. I don't learn from them very much. Otherwise, I really do try to read them all. And if you see something that's wildly different than the read, it's super cool and appropriate to just professionally call them up and be like, quick question, what is this? And every once in a while they're like, oh no, oh my God, I missed that.
Also, guys, make sure you read the bodies. Don't just read the impressions, because they will sneak stuff in there, or the impression will be auto text, and the body will be the real read. Like just the other day, Perry put in there bowel obstruction scene.
Yeah.
He meant to say no bowel obstruction, but still.
Yep.
Make sure you're reading the impressions.
And all that's to segue into, there is a time and place and clinical judgment on prolonged C-spine immobilization. There are plenty of reasons to do it, and you're allowed to. So just, you can apply these rules and as you continue to learn. And thank you so much.
So what is your practice now for intoxicated patients that you scan?
Oh yeah, except for yesterday.
Do you clear them?
It's a good question. When's the last, I'm trying to remember the last time I cleared an intoxicated person.
Forget about the last time.
just what is your
Let's say
practice
you're working with me tomorrow and you've got an intoxicated patient.
So, okay, so so my practice, in the absence of any other findings, so with a negative scan, yes, I do.
So it's okay to change the skeleton and to work it's okay to,
So like you know, put in numbers and numbers that say that even with intended patients, you're not gonna skip the CT. You're gonna do the CT if it's negative, and then you likely clear them.
also say, like, what degree of pain do they have after we remove the collar? I mean, if they're like, oh yeah, it hurts a little bit, I'm fine with removing it. If they like are rigid, they don't want to move at all, pain is out of proportion to what the CT looks like, I'm much more highly concerned about some sort of ligamentous injury. In those patients, I'll send them home with a collar and spine follow-up.
The documentation is pretty tenuous too, and as someone that was just posed for this, they will, I don't know, rip your chart apart. We can talk about it. But putting not intoxicated in the chart is.
Well, okay. First of all, sure that's true. I know you're not just trying to wing me.